too many people found out about their kidney disease in the emergency room.
Welcome to Healthcare Perspectives, a podcast by Siemens Healthineers about medical breakthroughs with the power to improve lives everywhere. You just heard from Dr. Salvatore Viscomi, founder and director of Carna Health. He is joined in this episode by Angela Neale, physician assistant and medical officer at Siemens Healthineers Point of Care. In this episode, they explore one of the most pressing challenges in modern medicine: detecting and managing chronic cardiorenal-metabolic disease before it's too late.
Hello and welcome to Healthcare Perspectives. I'm Angela Neale, a physician assistant with more than 2 decades of clinical experience spanning cardiology and critical care medicine. I've spent my career at the intersection of diagnostics, frontline patient care, and healthcare innovation. Today, I serve as a clinical and strategic partner at Siemens Healthineers. One area I'm deeply passionate about is cardiovascular women's health and the silent ways chronic disease can progress undetected, often for years before a patient ever feels unwell. And that is exactly what today's conversation is about. I am joined today by Dr. Salvatore Viscomi, founder and CEO of Carna Health, whose work in population health and early kidney disease intervention is truly changing what's possible in primary care. Today, we're going to talk about chronic kidney disease, diabetes, cardiovascular risk, how these conditions are interconnected, why they so often go undetected, and what clinicians, patients, and health systems can do about it. Dr. Viscomi, before we dive into the clinical details, I'd love for our listeners to understand who you are and what drives your work. You founded Carna Health with a specific focus on early kidney disease intervention and population health. Can you walk us through your background and how you came to focus on this space?
Sure. Thank you, Angela, for having me as part of this conversation today. I'm a physician. My background is in radiology, where I practiced at Harvard Medical School and Brigham and Women's Hospitals for many years. I became very passionate about prevention, mostly around breast cancer and lung cancer. And most recently, I've taken prevention in the cardio-kidney-metabolic space with Carna Health, where I co-founded, and I'm the CEO and the chief medical officer, where we built a digital platform to really disrupt the trajectory of these diseases, which are increasing in prevalence and mortality. And we're using point-of-care testing with our partner Siemens Healthineers in order to do that. So I'm very excited about the conversation today.
Thank you. As a PA who has spent years in cardiology, I've seen firsthand how kidney disease, diabetes, and cardiovascular conditions can have this compounding cycle that can truly shape a patient's health journey over a lifetime. You and I know that these unfortunate conditions are widespread and unfortunately often coexist, making them a challenge in primary care. How do you explain this cardiorenal-metabolic continuum to patients who may only be aware of one piece of it?
The challenging part around these diseases is about the early stages, and often even fairly advanced stages can be asymptomatic, particularly when it comes to kidney disease. And so not for patients to wait for symptoms before they talk to the doctor, but actually to look at their own personal and family risk factors. That's the most important thing, because we know that many people will crash into dialysis or end up in fairly advanced kidney disease before symptoms present themselves. For people to be aware of what these diseases are and that they may have them even though they might not have any symptoms that are apparent is, I think, really important. So education and awareness are really important. It's also really important to talk about how if you have kidney disease or obesity or diabetes or heart disease, that these diseases are all interrelated and they make each other worse. In the case of kidney disease, most people with kidney disease will die of heart disease before kidney failure. And so it's really important that you tackle these not one by one, but together. If you impact one of these diseases, by a rule, you impact the other ones in a positive direction. And certainly if you impact all of them at the same time, you really can do a lot of improvement in patients that often have more than one of these conditions.
Thank you. This interconnected risk can often go undetected for years by both patients and healthcare providers until the patient feels unwell, like you just shared. Why are these diseases so prevalent? How are they sometimes missed in primary care? And how does the cardiometabolic risk compound across a patient's lifetime? What are your thoughts?
It's a great question. Complex answer. I think it's different for different people. Of course, to be a little bit repetitive, the asymptomatic nature is a problem. If people had symptoms early on, they would go to the doctor and saying, hey, I have chronic kidney disease, and they would get treated earlier, but they're not doing that. So that's been a challenge. I think the other thing is some of the risk factors are going in the wrong direction. Diabetes, obesity, hypertension, and in part because of diet. Diet is a sort of a common denominator, and inflammation is another common denominator. So stressful lives and obesity also causes inflammation. So inflammation is another common denominator that seems to have increased as well. And then the last risk factor that we talk least about is heat. Heat stress, particularly for people that are working outdoors or spending time outdoors in manual labor, is sort of a newer risk factor that wasn't so much an issue several decades ago. And depending on where you live and your job is a new risk factor contributing to the causes of certainly CKD, then obviously the sequelae that result in heart disease and the metabolic sequelae as well.
Interesting. In my experience, women can face delays in diagnosis when their symptoms present differently than the patterns that we both were traditionally taught and likely was emphasized in medical training. Whether it's the cardiovascular disease, diabetes, kidney disease, important symptoms and risk factors may sometimes be overlooked, creating these missed opportunities for earlier intervention. In your population health program, what are you finding in terms of women versus men, these gender differences, and why are women more likely to enroll than men when asymptomatic?
That's a very interesting point. We know that in many parts of the world, including the United States, that women are often missed from a cardiovascular risk standpoint. In part of the way doctors and healthcare professionals are trained in terms of what symptoms people present with. And the classic symptoms for a heart attack or stroke can be different in women. And so that's been an issue. On the prevention front, in our experience, women have really taken the lead in very different parts of the world that were creating prevention programs for screening of cardiovascular-metabolic disease. On average, 2/3 of the individuals that enroll are women. Women seem to be more interested in prevention and also are the decision makers around health for their families. And they are bringing the men in their lives, so their spouses, their boyfriends, their sons, to prevention events. And so it's been really important for us to engage with women in terms of finding also the high-risk men that are not coming for prevention and screening. They are likely to be much more successful in bringing in the males into those programs. But it's been very positive feedback from women in terms of coming in without symptoms and being more proactive around their health and the health of their families.
We both have primary care colleagues, and this specialty truly, in my opinion, remains the cornerstone of preventative health. Yet time constraints and increasing patient complexity can make long-term risk assessment and preventative education challenging to deliver consistently. How does this reality and the reimbursement structures and workflow constraints that reinforce it limit what we can accomplish for patients? And how do you think this could be improved?
When it comes to cardiovascular-metabolic prevention here in the United States, we have the diagnostic tools available. So we have accurate point-of-care testing through Siemens Healthineers. We have incredible medications that are now available. There are fairly new classes of drugs called SGLT2 inhibitors and GLP-1s. You have the diagnostics, you have the medications, you have the digital tools and platforms to track patients. What's missing is policy that supports doing this at scale. And the current reimbursement schemes really reward the treatment of end-stage disease. Dialysis is well reimbursed. And so if you end up having kidney failure, end-stage kidney disease, that's covered. And the doctors that perform those services are covered, and the companies that perform those services are covered. And yet we don't have nearly the investment in preventing those diseases with policies. there's probably no greater return on investment if you were to prevent cardiovascular-metabolic syndrome in our population where we are today, given that it's easy to diagnose, it's easy to monitor, it's easy to treat with well-tolerated and effective medications. And so we are in a very good position to manage this problem in a much better way. And if we do, we're going to have better health span, better quality of life, and significantly decreased healthcare costs in this country.
Patients living in rural and underserved populations may face barriers, right, to preventative care, diagnostic testing, and certainly specialty services, which potentially limits opportunities for that early detection and intervention. How should we be thinking about these gaps, and what would be meaningful progress look like in your viewpoint?
I think rural health has been challenging for many, many, many years. I think there's an opportunity today. Again, given the technology that's available and the digital platforms and the telehealth, we can solve for a lot of the challenges in rural health. When there's less access to laboratory testing, we have wonderful point-of-care testing through Siemens Healthineers. When it comes to digital platforms, we have platforms that patients can be engaged with, can monitor them, can alert them about what to do next. And even when there's lack of specialists in a community, there's always telehealth, and there's also upskilling of primary care resources. And so rural health no longer needs to be an area of challenge. It's an area of opportunity. The tools are there. Again, it's an implementation problem. We need to invest in those communities. The technology is available, very effective. And I am optimistic for the future of rural health, given the technology advances and digital health advances that we have today.
So as you just shared a little bit about point of care technology and its impact, when point of care testing brings the laboratory insight directly into the clinical visit, allowing the clinician to assess the risk, maybe confirm concerns, and act immediately rather than waiting potentially days for results to come back, that changes that clinical encounter. What do you think testing closer to the patient means, and why is that so fundamental? And how does it shift the dynamic in the exam room?
Well, I agree with you. Point of care testing offers many advantages. I think the first one that comes to mind, because we do point of care testing around the world, is that there's an opportunity with real-time results for the clinician to talk to the patient before they leave. As opposed to laboratory testing, there's an order, the patient goes, maybe they don't go, and then they get the results in a few days. There's a phone call, a missed phone call, and the communication's often different, right? It's going to be over the phone. To me, one of the most important things is the communication at the time of testing. It relieves anxiety, and you have this very special moment where the clinician can talk to the patient about an abnormal result, about a normal result. That's important. Of course, the accessibility, right? This allows for people that would have difficulty or would probably avoid going into driving several hours into a city to get a laboratory test. And it brings testing to them, which is, of course, what people expect these days, to be able to get tested in a pharmacy, after COVID. These are where healthcare is going. So be able to bring testing to patients because they have other concerns, right? They have work, they have their families. That's another win. The other win is that with a drop of blood rather than venipuncture, which means, taking a bigger needle and putting it in draining blood, there are a lot of people that are phobic of needles. The point of care testing allows for people that may have concerns about getting tested to be less fearful of that. And then the urine testing is very simple, right? In terms of doing that, very non-invasive. So point of care testing, when it's accurate, is an incredibly wonderful tool that we don't use enough of.
From a clinical standpoint, markers like albuminuria or elevated A1C can reveal early cardiorenal-metabolic dysfunction long before symptoms appear, giving us the chance to intervene proactively rather than reactively. How are you using urinalysis, urine ACR, creatinine, A1C in practice to build a more connected picture of patient risk? And what do you wish or feel more primary care providers understood about these markers?
The most important is UACR. In every single program around the world, we, as a rule, include UACR. UACR is a test done in urine, so very easy to collect, incredibly powerful. And more recently, it's been shown to be an independent risk factor for cardiovascular disease like heart attack and stroke. With this one single urine test, a very powerful information around risk. Of course, we can add creatinine, which helps us stage kidney disease. And there are some causes of kidney disease that are often picked up with blood and not urine. But so urine is, if you had your choice, urine is more powerful. And then HbA1c is an incredible test for diagnosing diabetes and prediabetes. It really assesses sort of your glucose level over the course of several months rather than a single point in time. And so with blood and urine testing from a couple of devices, you can really capture the risk and stage of cardiovascular disease, kidney disease, and diabetes, right? And of course, with very other measures like blood pressure, we monitor, which is very easily done. And then obviously weight and BMI and waist to hip ratio are also really important determinants. So with very simple tools, you have very powerful data around identifying disease, predicting risk progression, and determining what are the next steps for that patient.
So, a little bit beyond clinical benefit, how does point of care testing support individual patient decisions, particularly for patients in rural or resource limited settings? A little bit about what you discussed earlier, where bringing diagnostics closer to the patient can minimize the loss to follow up and support earlier preventative care.
Absolutely. I mean, I think the point of care in our experience has been well received by all communities. They appreciate the convenience. They're more likely to come to a site that's convenient for them than to go for a wellness check. In many parts of the world, wellness checks are really non-existent and very difficult because of daily challenges. And so the convenience factor is really important, like we talked about. And again, they're more likely to come up for follow-up knowing that they had a very good experience of point of care testing, that when there is time for an annual or next 6-month screening, they're much more likely to come back.
Let's bring this home to patients. In your clinical experience, how do patients experience a delayed diagnosis? And what does it mean for them emotionally and practically when they learn how long this potential disease has been developing?
Yeah, unfortunately, we meet too many patients that have disease where it's irreversible, particularly when it comes to kidney disease. In many parts of the world and in the United States, to unfortunately a large extent, too many people found out about their kidney disease in the emergency room. And the only thing that can be offered to them at that stage is dialysis or transplant. What this means is that they're forever tied to either a transplant, immunosuppressant therapy, or to dialysis, which is very challenging, right? 3 days a week, 3 hours per session, can't travel as much, difficult to work, caregiver time. So it impacts them and their families and their quality of life. And the difference of identifying disease before end stage disease is that that's avoidable. That patients can either with lifestyle changes avoid that, or if they meet the criteria for treatment with one or several medications, they can slow down and stop disease so they'll never need dialysis. And that means they have a higher quality of life, that they are working and productive. Their family members also get to appreciate the health of their loved ones. It's remarkable the difference of having a diagnosis before end stage disease in terms of how it impacts the lives of the individual and the people around them.
I've seen in women that a diagnosis can trigger frustration, certainly guilt and anxiety, particularly because they often act as the CEOs of their family health, managing everyone else's well-being while their own health may go unchecked. In that context, how can point of care testing change their experience and impact their whole family from your perspective?
I agree with you. The women in our experience around the world, not just the United States, tend to be the most proactive around prevention and certainly appreciate the point of care testing, the convenience, and are able to bring their loved ones and their families, both men and women, with them, either at the time of the first prevention program or in follow-up. We definitely have leaned on women in our communities to take the lead and to support the community widespread prevention and screening of these diseases. And so our experience has been very positive. And I think both men and women do appreciate being closer to them and making it as easy as possible. And I think both also appreciate the communication that happens at the time of point of care testing rather than having to wait several days.
Cardiovascular, kidney, and metabolic diseases affect growing numbers of people worldwide, which with your company, you certainly have seen. How big is the CKM global burden, and where do you think the highest leverage opportunities are to interrupt it?
Certainly, this is in the billions of people. Chronic kidney disease alone is probably close to a billion people in the world. And then diabetes and cardiovascular disease are often very common in some populations that we're in. It's like 30 to 40% of the population. And so it's a massive problem throughout the world. Very few places in the world are spared of any of these diseases. The opportunity is with all of them, right? The opportunity is to identify any of these diseases in an earlier stage. We can do a much better job. Certainly, I would say historically, the unmet need is most around chronic kidney disease. It tends to be the one that may be the most asymptomatic for most people. And so starting there is a good place because you can identify disease very early before any symptoms, and you put people on a pathway of preventing cardiovascular disease as well. But certainly the best way to manage is to take it comprehensively. So in our programs, we do HbA1c because we want to tackle diabetes. We certainly monitor, identify people with obesity, CKD with blood and urine, and then the UACR from point of care testing, incredibly powerful for cardiovascular disease, along with blood pressure monitoring, right? So again, several tools, all very accessible, very reasonably affordable, are available and can provide real-time results.
Excellent. Access to laboratory testing can remain challenging in some rural and underserved communities, as we discussed earlier. And point of care technologies have the potential to bring that diagnostic testing closer to patients directly, right? Whether in community clinics, maybe pharmacies, mobile health settings. Where do you see the greatest gaps in access today? And how might expanding the laboratory testing, the diagnostic availability, help support earlier detection and intervention?
I think the gaps are not having enough awareness and education in the community. And so bringing the testing along with that education awareness is really the solution. And I think all the examples you gave are great opportunities and ones that we've utilized. Pharmacies are a great place. There are definitely research out there that says that more patients prefer care in a pharmacy than in their general doctor's office. We need to take advantage of that. Retail, malls, spaces are where people are going for other reasons, and to be able to find people that would never probably go to a wellness check. And again, churches, mosques, temples are places that we've utilized, again, with their community leaders. Sometimes they trust them more than they trust doctors. Putting it all together, it's not a single site, right? I think we have to utilize the clinics that we have. Mobile units are incredibly powerful and incredibly convenient, so we've utilized them as well. And point of care testing sits well. The combination of all these things, right, all these sites really changes the landscape dramatically. It changes the landscape from like needing a hospital or a large clinic and then going to a laboratory afterwards to going to somewhere that may be a few minutes away. And that's the difference between getting a diagnosis and not getting a diagnosis, right? That's the difference between a successful prevention program or the likelihood of prevention not happening. So all those things you mentioned, and there are likely more, it can be very creative, are really powerful tools that we should take advantage of to make it easier for people when there are no symptoms, particularly to be able to access care before they have symptoms.
Great insight. Thank you. There's a lot of conversation about artificial intelligence in healthcare right now. I think of AI as a connector that could help organize clinical complexity, identify patterns earlier, stratify risk, maybe offer personalized healthcare, and support clinicians facing this overwhelming amount of data and workflow demands. In your experience and thoughts, how do you see AI fitting into this cardio-renal-metabolic care landscape? And what excites or even concerns you most about its involvement?
What excites me about AI is that we are typically treating patients based on guidelines and treating them once they hit a certain threshold. And the truth is that there are people with earlier stage disease that are more likely to progress rapidly. And so using AI with good data from point of care testing and other sources of vital signs can really provide those insights in each community. What that means is, for example, someone with stage 2 kidney disease, based on guidelines, they would say, well, come back in a year or 2 years and we'll test you again. Well, with AI, it may say that, hey, we are concerned about your risk of progression. Even though you're early today, you're more likely to progress towards kidney failure. So it allows the doctors in that network to be more proactive and treat earlier. Those are the positive things for AI. The concerning part is if you're not capturing accurate data, or if you're applying data and analytics from one population and trying it to apply it to a very different population, it could be very misleading and problematic. For us, the predictive analytics are for each based on the data collected in that population. The other not spoken enough advantage of AI is the opportunity to upskill when there are not enough specialists. And in rural areas and in many parts of the world, there are not enough specialists, not enough nephrologists, cardiologists, endocrinologists. And so primary care is really the only resource that can manage this problem. And primary care has a lot of competing interests, right? The people are very reactive. People are going to their doctors, not for preventative health. So making it easier for primary care doctors, nurses, pharmacists to take care of patients that are more complex is possible now with AI as well.
So, true global improvement in chronic disease outcomes will require a multifaceted approach. Where do you see promising momentum right now?
Yeah, the primary momentum is that there have been resolutions passed in the World Health Organization and the United Nations that are recognizing certainly chronic kidney disease as a priority disease and cardiovascular syndrome, and realizing the large size of this problem and it being somewhat ignored. And you see in many parts of the world where infectious diseases have improved tremendously. For example, in Africa, the burden of non-communicable diseases is going to exceed infectious diseases for the first time, estimated in 2030. What I'm excited about is that there's been a recognition on an international level that NCDs have been ignored and that they're going in the wrong direction, and that needs to be changed. I think it starts there. I think what we like to see is that there's investment around how to do that. How do you do large scale prevention programs? And again, I think also it's the right time. I'm excited that the medications and the clinical trials around these medications are incredibly supportive in terms of these being incredibly effective, and more treatments are on the way. I'm also excited about the digital tools that are available, that patients could take advantage of AI now in terms of risk of disease, risk of disease progression. Lack of specialists may not be as nearly a big a problem as it was in the past, with primary care being supported. I'm really excited about the recognition on a global level. I'm excited about the technology there. And we'd like to see policy changes, country by country, to be able to support what the technologies that are available and get that in the hands of doctors and patients.
We've covered a range of topics today, from chronic disease prevention, gaps in care, the use of AI, the role of point of care testing, and certainly the patient experience, including laboratory testing. What else is important from the clinician standpoint to offer support and ensure good outcomes for our patients? What are your thoughts?
Testing is certainly important, a critical part, but can't be the only solution. I think education and awareness are really critical. And in fact, with chronic kidney disease, almost universally, over 90% of people with disease are unaware of it. There's a lack of understanding of what the kidneys do. And so I think primary care doctors and nurses and pharmacists, all of us can do a better job in terms of making people aware of the problem. Two is a diagnosis is not enough. There needs to be follow-up. Patients need to be supported and engaged to make sure that once they are diagnosed with the problem, that the next steps are followed up. If that means going to a specialist, did they go see a specialist? If not, why not? That means going back to primary care. Did they go back? Did they get their second screening done a year later, if that was what was indicated? And so really not stopping at the testing, but making sure that you close the loop, end to end. And I think the other thing is to support healthcare systems, support ministries of health with data. so they can understand where in their country, in their state, in their healthcare system, where are their hotspots, where are there areas where things are going well and things are not going well, so they can sort of identify that problem and be proactive. The really important part is to think about this as end to end rather than just saying we're going to make a lot of more diagnoses. The critical piece is getting that person to a good outcome, which means that you have to support your doctors, you have to support your patients and keep them engaged and educated, and you have to support your healthcare systems and ministries of health with data so they can allocate resources, which are often strained appropriately.
Thank you. And last question. So, Dr. Viscomi, if there is one message you want listeners to take away about primary care, prevention, and chronic disease, what is it?
Well, that's a good question. Difficult to pick only one. I would say that this is probably the biggest opportunity in healthcare in our lifetimes, where we have all the tools available to be able to really change the trajectory of a disease where mortality, prevalence, and costs are going in the wrong direction. And so with some policy changes, we'll have an incredible impact in the lives of billions of people around the world. It's easier said than done, but the one thing is that these are preventable diseases. And with simple tools and medications, we can really change this disease in our lifetime.
Thank you again, Dr. Viscomi.
Thanks for having me. Great conversation.
What I take away from this conversation is something I believe deeply. Chronic disease begins silently, so the biggest impact really comes from identifying health conditions early before symptoms appear. Early testing and ongoing conversations with primary care empower patients to make informed decisions in real time. And perhaps most importantly, it's being active in your own care. Be the CEO of your own health, know your numbers, speak with your provider, don't wait for symptoms. That active role you play as a patient may be the most powerful tool we have. Prevention really is the best medicine, and early testing enables better conversations, and access, empathy, and technology together can really change outcomes. So thank you all for listening.
You have been listening to Healthcare Perspectives, a podcast by Siemens Healthineers, pioneering breakthroughs in healthcare for everyone, everywhere sustainably. Subscribe to us and get the latest episode in your podcast feed, or visit siemens-healthineers.com/perspectives/podcast for more information. The intro and ending segments of this episode contain AI-generated audio. The opinions expressed by guests and contributors in this podcast are their own and do not necessarily reflect the views of Siemens Healthineers. Statements made by Siemens Healthineers customers and partners in this podcast are based on results achieved in their unique settings. Because there is no typical hospital or laboratory, and many variables exist, including hospital size, sample mix, case mix, and the level of IT or automation adoption, there can be no guarantee that other customers will achieve the same results. This podcast describes possible future ideas and concepts. It is not intended to describe specific performance and/or safety characteristics of current planned or future products. Their future realization and availability cannot be guaranteed.